𝒂𝒃, yes.
Hello everyone. My name is Huy Pham. I'm a neurosurgeon from Vietnam, and I'm the host today. Welcome everybody to ACNS Young Neurosurgeon webinar. The patron of the webinar is Professor Kato, who is the president of ACNS, and the chair of the webinar today is Professor Manabu Kinosita, who is the professor at the Department of Neurosurgery, Asahikawa Medical University in Hokkaido, Japan. And there are three speakers today. The first expert speaker is Professor Eckhard Matthias Kasper, who is the professor at the Department of Neurosurgery at Boston University, Chobanian Ivedian School of Medicine in Boston, USA. He will speak about Chiari malformation. The second speaker is Dr. Đinh Thị Phương Hoài. She's a PhD student at the Orthopedic Surgery Department and Organ and Tissue Anatomy Department at Hamamatsu University School of Medicine in Shizuoka, Japan. She will be speaking about primary malignant peripheral nerve sheath tumor of the caudal equine, case report and literature review. And the third speaker is Professor Ming Li, who is the Vice Chair, Neurosurgery Department of Henan Provincial People Hospital. He's also the Associate Professor at Jiangsu University in China, the Chairman of Central China International Neuro-Oncology Forum. He's an Associate Editor-in-Chief at Cancer Translational Medicine Journal. He will be speaking about prediction of IDH mutational status in WHO grade 2-3 glioma using hyperintense flaring combined with H1-MRS. Firstly, I want to invite Professor Kato to make an opening. I'm sorry. There are two discussions today. The first discussion is Professor Alexander Wozniak, who is the Chief of Neurosurgical Center at the Clinical Hospital in Philadelphia. He is also the President of the Ukrainian Association of Neurosurgeons. He's an associate professor at Department of Neurosurgery in Suffolk National Healthcare University. The second discussion is Professor Konstantin Karadjogov. He's a professor in neurosurgery at Department of Neurosurgery at the DK University School of Medicine in Tokyo, Japan. In moderation with me today, there's also Dr. Sukidas Chauhan from India. Firstly, I want to invite Professor Kato to make an opening remark.
Hi, everyone. So we are very much looking forward to three excellent speakers. So I think maybe we can have a lot of learning today. Okay, thank you.
And next, I want to invite the chair of our webinar today, Professor Manabu Kinosita, to chair the webinar and introduce the first speaker.
This is Manabu Kinosita from Hokkaido. It is my great pleasure to chair this wonderful session. I know very little about, for example, Chiari malformation and malignant peripheral nerve sheath tumors and other things. So I'm very looking forward to learn myself from each speakers. So the first speaker will be Dr. Kasper from Boston. He will be talking about Chiari malformation, right? So without further ado, I would like to listen to your presentation.
Thank you so much. Let me share my screen. Here we are. Is it visible to everyone?
Yep.
Yes.
Oh, wonderful. So I want to talk about Chiari malformations and their surgical management today. I have nothing. Oops. Let me see where I can drive my. I have nothing to disclose other than the institutions I'm working in Boston, and I'm privileged to also be part of a number of professional organizations. And I want to give my great thanks to Yoko Kato for inviting me a few years ago to join the Asian Congress of Neurosurgery to be part of your education team. So for today, I want to talk about a general introduction of Chiari's, definition, workups, epidemiology. Then I want to tell you about some surgical options that have been described in the literature, including some minimal invasive surgery, such as tubal extractor and endoscopic surgery. And then I want to summarize it with best clinical evidence, what works well for this patient population. And the talk is aimed at really the student and the early resident to get a fair idea about this patient population that is interesting and how to approach this problem. So first of all, Chiari malformations are mostly congenital. They're defined by anatomic abnormalities of the craniocervical junction. They are genetically co-modified, but usually de novo mutations. We get to that in a second. And the simple definition is a Chiari malformation is identified when parts of the cerebellum, the tonsils, are located ectopic below the level of the foramen magnum. And it usually happens because the posterior fossa is considered hypoplastic, causing the contents of the brain that is too full to be pushed down, and that results in impaired CSF flow. So it's a CSF circulation disorder. Sometimes, in addition, systolic blood pressure waves may further impact on the brainstem and can then create cavitations in the spinal cord parenchyma called a syrinx, which then secondarily can affect spine function. As a synopsis, the diagnosis in Chiari malformation is anatomical or radiographically, and most people agree that this occurs when the tonsils are displaced 5 millimeters below the level of the foramen magnum. One of the problems is there is no biomarker in blood, CSF, or cultured tissue, so the neurological examination is paramount, and neuroimaging is prime importance. And as you can see here on the left lower side, the tonsillar descent is visible by the yellow arrow, and in the coronal junctions, you see these two little pegs, just like a cork in a bottleneck. On T2 axial cross-sections MRI scan, you see a full foramen that is crowded, as we say, and secondarily a syrinx in the cervical spinal cord, which can extend all the way down. Clinical manifestations include elevated ICPs, cranial neuropathies, brainstem compression, myelopathy, cerebellar dysfunctions, pain, mainly neck pain and the distribution of a cape, and sometimes occipital headaches. And in addition, we can see syringomyelia, sometimes accompanied by scoliosis. The classic thing really is that patients present, when you inquire them diligently, about Valsalva-induced symptoms such as headaches, maybe associated symptoms. One of the problems is there are many asymptomatic cases with visible Chiari malformation on imaging, and the reverse is also true. There are patients that have rather little on imaging, but they have all the symptoms. One of the modern MRI scan technologies that we use is direct CSF flow measures through a pulse sequence called a ACNS sequence or a CSF flow sequence, where you can see in a normal patient appropriate CSF flow anterior to the brainstem along the clivus and posteriorly to the cerebellum, whereas in a Chiari patient, you often see an abrupt stopping of the CSF pulsations at the level of the foramen magnum and almost no CSF flow posterior to the cerebellum. The diagnosis, we said, is 5 millimeter posterior descent, and sometimes you find associated craniocervical junction abnormalities, which we will discuss briefly. The Chiari malformation was first described in Germany in 1891 for the first 3 types, where Chiari 1 is descent of the tip of the tonsils only. I usually say Chiari 1 has one problem. Chiari 2, in addition, has deformation of the brainstem on the 4th ventricle with descent of the tonsils, and usually comes with the spina bifida. And there's a Chiari 3 malformation, which really is herniation of larger parts of the cerebellum, usually in the setting of a posterior encephalocele, whereas a Chiari 4 malformation is really a different issue with cerebellar hypoplasia. Again, coming back to Chiari 1 malformation, cerebellar tonsils protrude into the foramen magnum without involving the brainstem. Rule of thumb is, in a Chiari 1 malformation, you have one problem. It sits right here at the junction with the tonsil having down, and often you find an associated syrinx right below it. The prevalence of hydrocephalus associated with Chiari 1 malformation is approximately 10%. Etiology, Chiari malformations can have different pathologies. They can develop prenatally de novo, so these are sporadic mutations, or they can be secondary to lack of vitamins and nutrients in the maternal diet. The first one is called primary or congenital Chiari malformation. They can also develop secondarily if spinal fluid is drained from the spine or from injury, or you have a spontaneous fistula, then we call it secondary Chiari malformation. Primary Chiari malformation is much more common than secondary. Summarize, Chiari-1 malformation do occur more often in women. They're the most common type of adult Chiari malformation, and it's more frequently recognized now in younger patients, which could be secondary to the fact that we simply scan more younger people for lots of reasons. A Chiari-1 malformation has a genetic prevalence for Caucasians. The others are equally distributed. Imaging studies. So we talked about the tonsillar descent, the crowding of the foramen, and sometimes we find associated bony craniocervical junction anomalies. And I want to go through this for a moment. The bony abnormalities that can be seen include atlas assimilation, atlantoaxial dislocation, clipal file anomalies, platyphagia, and basilar invagination. And I want to show this to you in imaging. In rare cases, you can also find what's called a Lückenschädel or a lacuna skull, which is really secondary to intracranial hypertension. So this is a summary of these findings. Atlantoaxial dislocation is usually a rotational abnormality between C1 and C2. Atlas assimilation means that the bony compartments of the condyles and C1 and C2 can be fused, and that can most frequently happen anteriorly to the clivus or posteriorly to the occiput. We can see clipal file anomalies where the vertebral bodies of the cervical vertebral column are fused. Platyphagia or invagination is seen here, which really reflects craniocervical junction instability. That's a specialty of our friend Atul Goel in India, who has described this extensively and fixes this actually with fusion. I do not want to talk about this today so much. And on the right lower picture, you see the scalloping of the inner table of the bone in patients who have increased intracranial pressure and so-called Lückenschädel. Other less frequently supratentorial found abnormalities are dysgenesis or absence of the corpus callosum, as summarized in the left lower corner, agenesis of the septum pellucidum, polymicrogyria of the hemispheres, and heterotopias of the gray matter. And there you can see there's overlap with some other developmental syndromes. The true natural history of Chiari-1 malformation has not been established. In most cases, it seems that patients develop normally and then they become symptomatic in adolescence or adulthood. So the typical presenting patient would be a female between late teens to early 40s, late 30s. That's the most frequent population I see. The mean age at presentation for symptoms is approximately 18 years. The frequency of associated serogomyelia or hydromyelia or mixed versions is approximately 40%. And some patients show a hollow cord syrinx where the syrinx extends the entire way down the spinal cord in severe symptomatic patients. Atlas assimilation is common. The other ones I've seen rarely. And I would say in my practice, 25% of patients come with associated anomalies. Chiari-2 malformation is also called a classic Chiari malformation. It involves the extension of the cerebellum and the brainstem into the foramen magnum. As you can see in the right lower corner, you see the compression of the fourth ventricle. And there often is a meningomyelocele from inborn spina bifida. So this is really two problems in Chiari-2 malformations. And this one is often called Arnold Chiari malformation, named after the two researchers who described this colocalization. In Chiari-2 malformations, you often see inferior displacement of the fourth ventricle, as you can see on the image, elongation and thinning of the pons, beaking of the trigeminal plate, which creates a weird angle here, and kinking of the junction of the medullary and spinal cord. We often see also secondary stenosis of the aqueduct, and occasionally you see the reverse, that the displacement goes superiorly. A Chiari-2 malformation is nearly always associated with myelomeningocele and therefore often detected prenatally with a sonogram at birth. And at this point, some groups have shown prenatal closure of spina bifida can release this tethered cord. These infants show often dysphagia, stridor, apneic spells, aspiration, and hydrocephalus is much more frequent in Chiari-2 malformation. So please have a look at these in pediatric patients that present with spina bifida. So what's the best therapy? The management of Chiari malformation depends on the nature of the malformation and the degree of neurologic impairment. It's pretty obvious. And I want to talk about three basic strategies: foramen magnum decompression alone versus foramen magnum decompression plus duroplasty versus foramen magnum decompression plus tonsillar resection plus duroplasty. So these are the three concepts, from rather simple surgery where you just decompress the bone to expansion of the CSF space to an additional step where you take out the tonsils. And these can be accomplished endoscopic with mini craniotomies, with bony surgery only, or with sectioning of the outer layer of the dura or both layers. And you can also open both layers of the dura into a duroplasty. So we go into this now into detail. So what are the treatment options? Well, first of all, wait and watch and do nothing. You can't make a patient better who has no symptoms. I often observe patients until imaging is complete. I get MRI scans, CTA scans in all of the patients, CSF flow studies in all of the patients, and my go-to surgery is posterior decompression without fusion. There are three technical positions you can consider. You can put the patient to the prone position. You can put the patient into prone position conquered and operate upside down from the head, or you can operate the patient in the sitting position. All of these have been described successfully in the literature. I would suggest you go with what your institution is most familiar with. And in my case, that is prone, because I'm a right-handed surgeon and I stand to the left side of the patient and operate upstream. So let's talk about bony decompression as option A, with bony decompression and outer dura mater release. Bony decompression B plus duroplasty, or C, bony decompression, duroplasty. Arachnoidal release is absolutely key. Tonsillectomy is an option. So this is how this looks. Treatment option A, rather simple. Bony decompression only has been widely described. You only need a decompression of approximately the width of the spinal canal, so approximately 2.5 centimeters wide and approximately 2.5 centimeters high. When you cut this bone out, it looks like a nice cutout at the posterior epiphyseal midline. And key is to also nick the dural band that is usually visible at the posterior rim of the foramen magnum and superior to C1. Especially in children, this works quite well. And there's enough plasticity that the internal compartments release and develop adequately. Treatment option B, medium complexity. You do a bony decompression and a C1 laminectomy, sometimes C2, and a duroplasty. I try to avoid the C2 laminectomy because it impairs your rotational and small neck muscle movements. I like the idea to take out the bone in the P fossa in two steps. You will see that in a moment, but the idea is you drill away the bone, take away the keel, make a Y-shaped incision in the dura. You open the dura in all directions, and then you patch in a piece of allograft or autograft to close the dural defect, which can be in several shapes. I like the Y-shaped duroplasty to close the gap, just like quilting, where you expand the amount of soft tissue available to allow a CSF pouch. Now, in my mind, the most relevant stop in addition to duroplasty is to actually do an adhesiolysis of the arachnoids to release the tethering of the tonsils. This was a good paper by my friend Lorenzo Giottomei, who described this in ACTA recently. They operate in the concord position where the patient is upside down, so the images are caudal is away from you, cranial is towards you. You're standing at the head of the patient. You basically open the P fossa, you untether the arachnoids. Oops, I apologize. Then you want to see that there's free egress of CSF from the fourth ventricle. And then you can put in some form of a patch into the P fossa, and they use allograft with fibrin tissue augmentation. Now, one of my colleagues in Canada, Kesh Reddy, and a resident described a short while ago the minimal invasive tubular retractor method for this surgery, where you can make a rather minimal incision at the level of the foramen magnum. You do under fluoroscopy, dissect down to the C2, C1 posterior fossa junction, and then through the retractor, you basically take out the posterior band of the dura. In rare cases, you can patch in a duroplasty. I have a hard time, to be honest, to advocate for this technique because I think, although it sounds like minimal invasive, you compromise your surgical ability to access the area and have good manual skills available. I think the disadvantage for someone who is not yet so experienced is that it's a really small surgical field and very deep down. So I think if you do make an opening, make this initially easy to you and go for a conventional posterior fossa decompression. This was how they did it, and this is out of the patient from paper from Keshreddy. This is now cranial is away from you, caudal is down, so you're standing behind the patient, looking upstream. There's the C1 arc, and you can drill down the C1 lamina. You then see the cut edges of the C1 arc, and they just split the midline to get a dural release here. So dural band release in young patients, I'd say preteen, this may work well, but I think it's only reasonably effective in some elderly patients or some adult patients. We'll get to this in a moment, why I think this is an available technology for children, but not so good for adults. Now, this is really the paper that I think all of you should read about the meta-analysis, what is most effective in Chiari malformations. Is a beautiful systematic review of techniques and outcomes by the group around Jian Zhao. They classified many 770 articles into surgical techniques and grouped them into group 1, which is bony decompression only and dural band release. Group 2, again, just as I said, bony decompression and dural opening with duroplasty. Group 3, bony decompression, resection of the tonsil, and possibly actually a shunt. Group 4 we can ignore for this purpose. So this was an excellent study where they were able to analyze more than 1,200 patients. And the first thing that I thought was surprising was that only 80% of Chiari patients show clinical improvement. Up to 20% of patients remain the same, and 6% of patients actually got worse. So as much as we want to be on the winning side and tell patients this is a low-risk, high-yield surgery, there is a significant group of patients, 1 in 5, that will have persistent symptoms post-surgery. And one of the reasons may be that there's so much overlap with other headache syndromes. So be careful about promising too much of an outcome. Now, the question is, as a simple summary, what is most effective? And if you look at the first 3 groups, it was very evident from their analysis that patients with bony decompression alone and only dural band cut did clinically significantly worse than others. There was less success in relief of symptoms, a significantly higher number of reoperations, and significantly more patients with persistent headaches. And that's the reason why in adults, I would not advocate for that technique. There was no statistical difference between patients that had bony decompression and duroplasty and those who had bony decompression, duroplasty plus tonsillectomy. So in general, it appears that bony decompression and duroplasty is enough to do, and it doesn't carry the risk of a tonsillectomy, with the exception of patients that have very large syrinx, and few of those did significantly better with a tonsillectomy. However, what is really remarkable is that the overall morbidity across all groups, as I said, was just about 20%, with 6% of patients post-Chiari decompression having a new motor deficit, which I thought was a high number, and a new sensory deficit in 12%, which can well be if you include posterior occipital neuralgias or paresthesias. But when patients are done with a bony decompression, a duroplasty, and a tonsillar resection, they had twice as much complications compared to the group 2 that had a bony decompression only and a duroplasty. So that is, in my mind, a strong argument for performing posterior fossa decompression, bony removal, C1 laminectomy, and duroplasty only. And I add in the adhesiolysis of the arachnoidal webs that tether down the tonsils. So this is how I do it for Chiari 1. And we've published this nicely. Dr. Lam and I published first a paper of how we open and close the posterior fossa in 2012. And then we followed up with a small series of our first 20 patients, I think it was, of Chiari malformations. And at this point, I've done 100 Chiari malformations, and I tell you a few things in a minute. What you need is general endotracheal anesthesia, obviously. Sometimes they do intraoperative monitoring if the patient is tight, and also to monitor the acoustic nerve. You should use image guidance, not because you can't find it otherwise, but to map out the occipital sinus and the torcular. I always use the microscope. I do a craniectomy, a C1 laminectomy, I resect the arachnoid, and I do an autologous duroplasty. So I harvest the dura from a patch superior to the incision and close it, hence you have no cost and no allergic reaction. And we have a less than 1% rate of CSF leak with a dural graft. This is from the paper we've published. Please look at this. It summarizes this technique nicely. These are the steps. I put the patient in military position. I make a mapping of the torcular and the transverse sinus. I extend my incision 2.5 fingers above the torcular. This is to harvest the pericranial autograft, and then the incision inferiorly to resect. You go through a general midline incision. The idea is I place 2 burr holes left and right. I use a regular craniotome, then I take out the midline keel. Once the midline keel is removed, you can basically drill out your C1 lamina. And once that is accomplished, I open the Y-shaped dura, just as shown here in step 7, to put in the dural patch. It's unfortunately not the best photo, but it's in our publication. This is how it looks post-op outcome. Posterior fossa decompression, approximately 3 centimeters above the posterior rim of the foramen, just about the width of the spinal canal. I get a post-op CT scan 4 hours later to rule out a hematoma. You immediately see that there's CSF space around the brainstem. Day 1, I get an MRI scan showing that there's a pouch of CSF flow, and on C2 images, you can see there's immediately space. And then I get a 3 months follow-up MRI scan to demonstrate post-surgical outcomes. There's a rare adjunct that I've read about and discussed with my friend Shlomo Constantini, that some patients with a large syrinx may benefit from a syringo-subarachnoidal shunt. I have not done this personally in my practice, but it seems to be very helpful in a younger patient population. A midline myelotomy and put a K-tube in here to drain the syrinx into the subarachnoid space, which is accessible, and that seems to have a good effect on the time frame of decompressing the syrinx. So let me just summarize. Clinical results are encouraging in general. Improvement of symptoms is reported in 60 to 100%. In my practice, it's above 85% improvement. Results differ based on the surgery performed. I strongly advocate to do a bony decompression and a duroplasty without the tonsillar resection. Bony decompression alone has a higher rate of reoperations. Bony decompression and duroplasty, by definition, has in the literature more CSF complications. But if you do use an autologous autograft and then you suture it in and you glue the suture line, our CSF rate of complications is less than 1%, which is a really favorable number. Most patients show a decrease or near resolution of the syrinx, especially if you add in the tonsillectomy. But I only advocate for this in very large and symptomatic syrinxes, and most patients show significant improvement of related symptoms. Summary: the descent of the cerebellar tonsils was defined as 5 millimeter or more below the foramen magnum. Disruption of the CSF flow can cause formation of the syrinx. Sometimes they come with spina bifida cavitations. In my practice, that is less than 20% of the population. So really watch out for this. And if correctly diagnosed, the therapy is surgical and can prevent further deterioration. Thank you very much.
Yes, that was a great lecture. Thank you very much. I would like to have some discussions here before going to the next presentation. Will that be okay?
Sure.
Okay, so we have a wonderful expert panelists today. Is there any discussions or questions that you want to? Okay, go ahead, Rajan.
Yeah, hi. Thank you, Prof. Casper, for this wonderful presentation. We're very vivid and we learned a lot. There are few things that remains controversial and needs to be addressed in Chiari, like what is the size of the craniectomy that everybody agrees upon is a standard craniectomy. Second thing is, what is the dural prosthesis recommended? Do you take a facial attack graft or a graft from the site itself as a dural substitute? Third one is what defines a failure and what defines a success in FMD? Whether do you evaluate your results based on standard outcome scales like Chiari, the Chicago Chiari outcome scale, which came back some years ago? And also in cases of large syringes, would you straight away go for syringosubrecognition or only rely on a FMD?
So
Can
thank
you
you for these
just give
questions.
your
Excellent
recommends?
questions. So in terms of the size, I think make it practical and think about what is the problem. It's the constriction at the level of the foramen magnum. So you need the width of the spinal canal. That's your decompression in terms of how much craniectomy you should do. And don't make it too high. 2.5, 3 centimeters is good enough because it's really just a cork in the bottleneck right at the bottom of the P fossa. Sometimes you see a very tight P fossa, then you can extend your craniectomy a little bit superiorly, but don't make it too big because the cerebellum will sag into the opening. And there are cases described where patient had significant stretch injury to a P fossa that was too wide after the decompression. So there can be, it's very difficult to operate them in the second setting if the decompression is too wide. So I go
So you
3
say
centimeters.
there is no standard definition. It
No,
varies.
no standard. So you need to study your films carefully. And I think the width of the spinal canal and then about 3 centimeters high is a good number. And more recently, people have even implanted cranioplasties in the superior portion, but they did the duroplasty to gain access to it. I do not do a cranioplasty. I think that defies the purpose, but I would say 3 by 3 centimeters is easy to remember. And then don't go too high and don't go too wide because your cerebellum sags. Second question, duroplasty. I use pericranial autograft. And the reason is very simple. It's the best material available in the same incision. It is the same as the dura on the other side of the bone, if you think about it phylogenetically. And it has the perfect consistency in almost all patients. And I've done now 300 cases, P fossa decompressions with duroplasties with a 1% CSF leak rate. If you do this really well, that is by far the best material. And you do not have a second morbidity from an incision at the fascial ladder, right? So from a patient perspective, one wound, one pain, one access, excellent material, good outcomes, cheap. There's nothing better. I wouldn't use allograft if you can avoid it, always allergic or inflammatory reactions. It increases your cost. And some patients have pretty bad inflammatory response to it. And it's much harder to stitch it watertight. So I use a 4-on Neurolon running stitch. I tent up the pericranial autograft in 4 corners, and then I really run in a circle, and that has worked out really well. Third question was, how do we evaluate outcomes? Yeah, Chicago outcome score is a wonderful way of doing it. In my practice, every patient gets a Chiari questionnaire at every single visit, and we test every single aspect. And I think it's wise to use quantifiable, validated tools that tell you what is the degree of headache, what's the extent of paresthesias, what is the impairment before, during, and after. So yes, you should evaluate them, and the Chicago score is a good one to use. And your fourth question, can you repeat that, please, was?
When do you define a failure? Is there a time limit?
So I want to see the patient be significantly improved and no post-operative complaints at 3 months. You see that a lot earlier. Most patients have almost immediate relief of headaches, especially Valsalva-induced headaches. But obviously they have significant neck pain from the operation. So you need to take the first week out of the equation. All my patients, just to add this in, are placed in a hard collar post-operatively. And the reason is a technical reason in my practice. I think if you put in a duroplasty patch, a lot of the CSF leaks come from the fact that the patient starts rotating the head with the duroplasty and there's stretch on the graft. And I think if you put the patient for 10 days into a hard collar, They have less pain because they don't rotate the head. The patch heals in much nicer, and I put all patients on anti-inflammatory drugs. Ibuprofen, 400 milligrams 3 times a day, and a muscle relaxant really does wonders. Patients are off narcotics by day 3. They go home on day 2 or day 3 after surgery. Has really been a good regimen in my hands.
Thank you very much.
Okay, thank you. So we have 2 more. So Dr. Chauhan, please.
Yeah, hi. Hi, sir. Really interesting topic. And I would like to put a question. It's regarding one of the patient opinions I gave last week, and I was a little bit confused. There was the 60-year-old female who was admitted in the medicine department due to a small basal ganglia bleed. She had a hemorrhagic stroke, but it was a small bleed and patient is walking, talking. Her general condition, she is a little bit weaker. You can say that her power is 4+ in all the 4 limbs. So when they did the scan, they found an incidental finding of Chiari malformation. I went and I checked her clinically, and she has increased DTRs, everything matching up with the Chiari. Now my question is, should I really intervene and operate her, or because she already has a small hemorrhagic stroke, or will it give her a risk of another hemorrhagic stroke tomorrow because she's already in the category? Second thing, she's already 60+ by age. So is it the right thing? I'm really confused.
So I'm not confused. I would make this very simple. You wait until the hemorrhagic stroke has resolved. You work the patient up for all stroke risk modifying factors. And the surgery as such is so benign. It's a 2.5-hour case. There's minimal blood loss if you do this well in the midline, that you do not add additional risk for creating stroke unless the patient has tight foramen and the vertebral artery is compressed, or you have some other pathology that is to be taken care of. If a patient is truly symptomatic, meaning they have these Valsalva-induced clinical symptoms that are clearly fitting the picture of a Chiari, I think everyone deserves a decompression, whether they are 20 or whether they are 60. Not because I like the job so much, yes I do, but because actually the patient miraculously describes often afterwards, I didn't know how it feels to be normal. So when you say she only has hyperreflexia, I don't care, because that's not an impairment. That's just a myelopathy finding, right?
You're right.
But if a patient has headaches,
asymptomatic
nausea,
now.
dizziness, so if you diligently ask them about, do you have trouble when you pick up books from the top shelf, or supermarket shopping is hard at the top shelves? You never paint the ceiling at home because looking up makes you dizzy, or they have tinnitus, or they have headaches wherever they are. A patient may not even know that they have had symptoms for most of their life. And a lot of them have been treated for migraines because people never ask them what the association of the symptoms are. So I think wait for the basal ganglia bleed to settle, give them some time. 3 months later, you bring them in, you re-examine them without the neurological deficit of the acute deterioration. If the patient is truly symptomatic, by all means, it's a simple operation, and maybe they deserve it and need it, and they will be very grateful if they suddenly can walk and are not dizzy.
Thank you. Thank you so much.
Okay. And the last question from Dr. Karagiozov. Right?
Yeah, sorry, I'm supposed to do 2 comments, but if there is any question further on, okay, let us listen maybe first to the questions. I'm sorry for that.
Okay. So
okay, if you would like me to comment, I would like to go for the comments. That's why.
Yeah, please.
Why not? Yes. Oh,
okay, because this was really an excellent presentation.
Yeah. I have one more person raising their hand. So Dr. Pham?
Yeah. Yes, I have a question. In some cases that with a Chiari malformation with syringomyelia, but on the MRI we don't really see severe compression on the central canal. Do you use any imaging modality to evaluate CSF dynamics to see the CSF flow through the co-obstruction side? And does it have any implications on the indication for surgery on those cases?
So briefly comment again, every single patient should get a CSF flow study, which is a pulse T2 sequence or CNS sequence, whichever way your radiology department does it. And the key thing for me is the observation there's asymmetric flow. Sometimes you see no flow, then it's obvious. But if there's no posterior flow around the tonsils at the foramen magnum, as opposed to posterior and anterior flow along the clivus, then I think you have a strong correlation that there's a CSF flow impairment. I get a CTA of every single patient to assess the vessels, to make sure that I'm not missing a vascular decompression either. And there are patients that have less than 5 centimeters of tonsillar descent, but they have all the symptoms. So you need to remember, an MRI scan is a static thing. You lay down the patient in the supine position, maybe very different from the patient being upright, where you get sagging of the brain. There have been studies done in an upright MRI scan that you get a different anatomy with more than 5 millimeters of difference between upright and lying down in just anatomy of the foramen magnum. I've always wanted to do the study as a comparison to the operation and compare standing and lying down MRI scans before and after. But we have very few standing MRI scans in the United States, and the insurance doesn't pay for a second scan. But I would love to do this study. If somebody wants to do it with me, I think that would be instrumental. And yes, patients with a Chiari 0 or Chiari 1.5 still benefit from the decompression, which is very hard to understand. But there have been a few studies out there. Tiet Matthiessen from the EANS and the Acta Neurochirurgica journal has tried to really sort of make people interested in this syndrome, because we don't understand the physiology really completely. So there may be more to it than what you see on the scan. And the diligent clinical assessment, I think, is more important than what you find on radiographic imaging.
Yeah, thank you.
Thank you. Okay, so for the interest of time, I think we have to wrap up. So I would like to have a comment from Dr. Karagianov.
Yes, thank you very much. Just for the completely, thank you, first of all, thank you very much for the excellent presentation of such a complex topic, and it was very instructive to all junior and even more senior members. I would like really to focus on few points. Chiari position of the tonsils is hardly to be considered for the future reliable phenomenon. Flow dynamics is most probably going to be the categorization of our problem in the craniovertebral junction. So assessment of the flow dynamics, which is, well, we can assess it by CINE, but or all the other modalities with flow void, but actually is bidirectional. And we do not know exactly what is the summary and the total effect of this kind of dynamic. So we need some kind of quantitative assessment. And this quantitative assessment is not yet here with us, but probably computerized flow dynamics, CFD, may be having a future in that, and we will have dynamic assessment in numbers to decide about the management at different points in the craniovertebral junction. That's why the position of the tonsils is not important. When we put a lumboperitoneal shunt, we usually see that the tonsils will even go down sometimes for 2 millimeters or 3. The second point, definitely a very good illustration of the techniques of surgical approach to the problem. The resection of the tonsils is something that does not lead to much effect. And for instance, in the group which I was cooperating, it is done only if that is impeding the outflow from the fourth ventricle. Otherwise, it is not justified. They are usually atrophied completely. Probably in general, I expect that the syrinxes, particularly when they are associated with some kind of severe Chiari, are better not to be treated surgically at the very beginning. Better to await the craniovertebral junction effect and then to decide about the syrinx. Syringo-subarachnoid shunts do work, but sometimes they need additional approaches. They are not accessible from the main. So that is better to be left later. additional arachnoiditis is induced and so on. Okay, that's all I can say. Thank you very much again.
Okay,
So
thank you very
excellent
much.
comments. I just want to comment on one item. So you can
Yes.
quantify the CSF flow at the craniocervical junction. I've done an interesting study with Carl Hallman and Rafiq Badelia, both from Tufts University, where you put the patient into the MRI scanner and you make them cough through a measurable breathing device. So you know how much speed of coughing is necessary. And then you can actually measure the true CSF flow speed as a vector across the craniocervical junction. It's just a very elaborate study. And the unfortunate thing is a lot of patients don't want to have an additional study, and a lot of insurance is not going to pay for that particular scan. But we are learning, as you said, that the true CSF impairment at the level of the junction is probably going to be the classification of the future. So I agree with you entirely, and thank you for your thoughtful comment.
Yeah, absolutely. Thank you for the indications for the cough, because standardization of the techniques for this evaluation is very difficult. Thank you very much.
Okay, thank you very much. So for the interest of time, I think we have to move on to the next presentation. Well, Dr. Kasper, thank you very much for a very nice presentation. So the next speaker will be from Dr. Huai, and she'll be talking about primary malignant peripheral nerve disease tumors. So go ahead with your presentation. Okay.
Yes, thank you. Maybe I need to share screens. Yeah, can you see my screen?
Yes.
Yes, thank you. Thank you, Professor 𝑦𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂𝒂 Thank you a lot, Professor Kato Yoko Sensei. Today I had a small speak for the K report and primary malignant peripheral nerve tumor of the codiaquina K report and review literature. So introduction, malignant peripheral nerve tumor and BNSD very low, approximately 0.004%, and malignant peripheral nerve cysts are common located in trunk and extremities, and incidence of primary intramedullary very so rare, and only 24K found in the literature. So this study, I want to report the K reports, the NPNSD of the codiaquina, and review in the literature and discuss medicine and also prognosis this K because NPNSD very aggressive tumor. The K reports, the 62-year-old man present with the gluteal and posterior femoral band, and the basis no more is the motor power. And but he need to gain walking cane, Ppsg negative, but often difficulty urinating. MRI showing here, you can see the heterogeneity well circumscribed mass L5 level isointensity T1 and hyperintensity T2, and also enhanced after contract injection. And the mass show atramedular and intradural and central position and slide to the left side, and showing here the Y arrows. And the tumor differential diagnosis with the schwannoma and neurofibromatosis. The patient underwent laminectomy, L4S1 posterior approach, and dura master open meticulously, and tumor shock tumor, and contain the yellow fluids at the L5 level. And so it the L5 nerve roots involve the dorsal root less of the L5 left spinal nerve. You can see here for the L5 spinal nerve. And tumor is identified clearly and carefully dissection the tumor from the nerve roots intact. First, monitoring show either normal and tumor resection and L4S1 recapping. After that, the pathology show the S100 SOE10 and 𝑛ephropromatosis positive. K67 so higher with the 40.1%. P53 positive and H3K73 weakly positive. After that, the patient underwent the MRI and showed the operation. The tumor completely removed, and also the patient were intact and no complications observed after surgery. Because the patient's diagnosis with malignant peripheral nerve tumor and MPNST, so radiotherapy with a high energy radiotherapy with a fatigue rate 25 times. And now the patient is normal and 2 months after surgery. And result and discussion, the rare case reviewing the literature and treatment and prognosis. So the rest, because the MPNST very are malignant and locally aggressive soft tissue sarcoma, but very so rare in the spine, only 0.001%, and MPNST comprise 5 to 10% of soft tissue sarcoma, and intradural MPNST so rare. I find the 24K primary intradural MPNST and show it table the next slide. This here the review in the literature for the 24K, and MPNST has a relationship with neurofibromatosis for in the 24K, and also the patient underwent total resection and radiotherapy after that, but outcome very poor for the patients because the recurrence and metastasis, especially metastasis in the brain system and the lungs. So it's here the treatment, surgery or radiotherapy or chemotherapy. And surgery is best for the MPNST, especially the total resection. And after median interval 5 to 32 months aroused, and radiotherapy to help for the patients, and recommend for the to apply the radiation myotherapy in fatigue rate in total recommend. But chemotherapy is not clearly, and so now is not recommend for the treatment for the patient with the MPNST, especially spinal. And further study for the treatment MPNST, because relationship with of the MPNST to the neurofibromatosis type 1. So a lot of study now focus on the neurofibromatosis type 1, and especially focus on PRC2 alterations, because change and PRC2 may play the decisive role in the MPNST development. And PRC2 function and mutations in the MPNST, and for the PRC2 component EED, EZH2, HUZ12, and RPPP47, As nowadays in the future study to elucidate detail whole loss of the PRC2 component EED and 𝑈Z trail contribute to the management and identify the EZH2 potential therapy targets. And nearly a future study for the treatment MPNST, the submit carbon ion radiotherapy to help the patient. But this study is a 𝒂𝒂𝒃 and 3K follow-ups and need to and after study and the patient control for at least 1 year after compile the surgical resection and addition carbon ion radiotherapy, but need to study more and more to elucidate the efficiency of the carbon ion radiotherapy. And conclusions. Today I want to presentation for the primary intradural MPNST very aggressive tumor and high recurrence and also after broad total recession and has significant potential for the leptomeninges and systemic metastasis and treatment of the very primary intradural MPNST, especially cervical tumor and combined with the hydro radiation, I recommend. And overall, the prognosis is very poor. Thank you.
Thank you very much for a very rare presentation, very rare case, I would say. I myself have only one experience of a malignant peripheral nerve tumor in the acoustic, but not in the spine yet. Is there any question or discussion that you would like to go ahead with? No?
Just as a comment, I think your summary slide of the treatment algorithm using radiation therapy as an adjuvant therapy should be a must, given that gross total resection rates lead to 30% recurrence. All my patients with malignant peripheral nerve tumors I immediately discussed at the sarcoma board, and I think radiation therapy at this point in the literature should be a mandatory adjuvant. Chemotherapy, very interesting. Your slide about the different relationships to neurofibromatosis should probably be trialed as well, but as in all orphan diseases, when you have very low incidence of disease, it's hard to make a trial because you cannot accrue patient in a single institution. So I always want to encourage the professional societies to set up an interest group, and maybe you can write to one or two of the professional societies and say, are you willing to make a multi-center registry through the professional society that the few people that have experienced this in their practice can collect the data jointly, and then there's a group publication out of it that helps everyone.
Yes, totally.
Thank you.
A prospective observational study, I would say. Is there any other comments or questions? Yeah, I have one. So regarding the chemotherapy, were you able to find any preferable chemotherapeutic regimens at this point? I'm sure that it cannot be proved effective, but will you find anything in the literature?
Yes, thank you. Thank you for your questions. And now is the chemotherapy, radiotherapy is the just find the reference, especially I find the SS and spinal surgery and related research and show the 3K. And I'm not sure a long time for the control, but this a new thing for the patient, especially MPNST in the spinal. And so I need to follow the patient. This my patient is a long time because it's now only two months after surgery. So not a lot thing I want to talk is. So I need to follow the patients a lot and find to something for the myelopathies after radiotherapies. Yes.
Okay, thank you. Any other questions or comments? No? Okay, so that was a really nice case presentation, and I hope you can do some follow-up presentation at some point somewhere. I'll be looking forward to that.
Yeah, thank
Okay,
you,
so
Professor.
thank you very much. So I would like to go to the last speaker, Dr. Lee, and he'll be talking about the prediction of IDH mutation status using MRI, I would assume. So I will be very much looking forward to your talk. Dr. Lee, can you go ahead? Are you prepared?
Yeah, can you hear me?
Yes.
Yeah, thank you. I think I presented this. I presented this one before, and I presented this slides in many conferences. I think some people maybe know this one, but this is the first time presented for the ACNS Young Neurosurgery webinar. Thank you, Dr. 𝑦𝒂𝒂𝒂𝒊, and thank you, Dr. 𝑬𝒒𝒂𝒂𝒊𝒏𝒈 and the chairs. Thank you. Actually, this project is developed most 𝑏𝒈 team. So the topic is prediction of the IDH mutant gliomas using hyperintense flare in combined with MRS. And mainly, first I introduce my hospital. First, this is here China. This is my province. I think maybe the largest province in the world. Professor Yuhan worked here before. This is my city. This is Yellow River. This is Shaolin Temple. This is my hospital. Professor Yuhan is my former colleagues. They worked here for 4 years. So we work in same department. And then Professor Yuhan supervised me some projects. I think Dr. 𝑦𝒂𝒂𝒂𝒊 visited here for many times before. So this is IDH. So what's IDH? IDH significance of in gliomas. As we know, most low-grade glioma is IDH mutant. For astroglioma, nearly 70% is IDH mutant glioma. For oligodendral, nearly 70%. For glioblastoma, 3% glioblastoma is IDH mutant. Secondary glioma, nearly 80%. Right now, advancements in IDH diagnosis and clinical research. IDH, how to detect IDH? There are several methods. First one is antibody testing. Second, Sanger sequence. The next one, 2GG MRS spectrum. The last one is mass spectrum. Actually, right now, how to treat the IDH mutation is a very hot topic in the neuro-oncology area. But last year, IDH inhibitor, people published on the New England, the Journal of New England, they show the good result. The second is IDH vixen. The third one is a NAMT inhibitor. The last one is glutamine synthesis inhibitors. IDH inhibitor last year, this paper published on the New England Journal of Medicine. IDH inhibitor significantly improves the progression-free survival of low-grade IDH mutant glioblastoma, because of low-grade GBM, 70% is IDH mutation. So this is very important. I think IDH inhibitor will take place the TMZ soon. I think in US and Europe, this most clinical staff can issue this drug for patients. But in China, the related clinical trial is ongoing. So I think this at the end of this year, Chinese patients will can get IDH mutation. So WHO agreed on the molecular types of the adult diffuse gliomas. Actually, WHO divides the glioma as 4 grades, grade 1, 2, 3, 4. But based on the IDH mutation and the 1p19q co-deletion status, we divided the glioma into three types. First one, IDH mutation with 1p19 co-deletion. Second one, IDH mutation without 1p19 co-deletion. The last one, no IDH mutation. That means IDH wild type. So grade prognosis of different grade and the molecular types of adult diffuse gliomas, we can see the grade 1, 2, 3, 2, 3, 4 have a significant survival. For the low grade, grade 2 have a good result. Overall, IDH mutation with 1p19 co-deletion also have a good survival. So how to use a conventional MRI to predict IDH status? Preoperative is of significant clinical importance. If a patient go to your outpatient department, he asks, "Oh, this is IDH or not?" He just have a regular MRI. How to tell the patient this question? I think this is a very important and meaningful for patients to know more and more information. So we know what's T2 flare mismatch sign. This is I think this is popular during the past 5 years. So T2 flare mismatch sign is completely or nearly completely uniform high signal on T2, and the flare should be low. This is should be opposite. Treat exclusion criteria, necrotic activities, small cycles, cesses, no enhancement. Tips to avoid potential misjudgment: avoid using T2 flare mismatch in pediatrics patients. That means we don't use T2 flare mismatch sign for the young patients. And in T2, cortical green matters within the tumor maybe show relatively low signals. So on T2 flare mismatch sign by Dr. Tarak, my former colleagues in Mass General Neurosurgery, we worked together for 3 years. He published one paper on T2 flare mismatch there in low-grade glioma. His paper shows diagnosis of IDH mutant as trauma using 3 combined parameters. Patients under the age of is 45. Tumors larger than 6 cm in diameters, displaying T2 flare mismatch sign. Specifically, sensitivity and the PPV are 94%, 27%, and 88%. Dr. Tarek published this paper, so I think this is very meaningful. So I joined his research directions. Actually, in some department, if the patient is younger than 45, and the tumor located on the frontal, most of the time is the DH mutation. So this is the standard the T2 flag mismatch sign. From here, we can see the T2 is very uniform, as a very high signal, and the flare is very low. It's opposite signal, and this is a T2 mismatch sign. If we saw this one, mostly this is a DH mutant. This is the excluded T2 flare mismatch sign. From here, there's some small low signal in the flare sequence. So we excluded this, and this is also excluded pictures. There's for the T2, there's not a very uniform T2 high signal. There's some heterogeneous signal. And this is also, there's an uniform high signal. This is excluded. There's a bigger cavity there. And this means that there's a necrosis cester without enhancement, which does that not meet the criteria for T2 flare mismatch. We should have the uniform or nearly uniform T2. This one is also this is a cortical green matters within the tumor on T2. Show relative low signals. However, this finding should not include the possibility of T2 mismatch cell. So what's the mechanism for the T2 mismatch cell? Some people said this is related about microcystic changes, but some people say the Dr. 𝑑𝒂𝒂𝒃 and other found that in 8 cases there's a significant correlation, but Dr. Patton said there's no related. So genetically, people said T2 flares. Genetically, it's believed that the T2 mismatch cell is closely related to the motor pathway. So this is a mismatch cell. We can see there's some cystic here. There's some macrocystic changes here. So this is the T2 mismatch cell and versus hyperflare rim. From here, from A and B, we can see A is a uniform T2 flare. B is a low signal on flare. So this is the opposite. So we say this is a T2 flare mismatch sign. C and D, we wanted to show that's the hyperflare rim. We can see on the D, we can see there's a flare rim. So this is a T2 flare mismatch versus hyperflare ridge cell. MRS I think is very popular in most hospitals. MRS is a non-invasive imagers muscles that really relax the concentration of metabolism within the body. Most of the time we know CHO. CHO means the tumor growth or not, or some is infraction. AA means glial. AA is another thing. So characteristics of glioma in MRS significant in CGO, significant decrease in ANA, and moderate decrease in CR, decrease in ANA-CR ratio, and increase in the CR in the CGO to CR ratio. Both the CGO and the CGO2 CR ratio are positively correlated with the grade of tumor. So this is a study conducted by my research team. This is a multi-center retrospective study was conducted to the other patients with adult diffuse gliomas at Henan Provincial Hospital and the first affiliated hospital of Xinxiang Medical University, also in my province, from the 2018 to 2023. Inclusion criteria meet the diagnosis criteria of gliomas. All patients underwent surgical treatment, and we got the pathological results and the molecular diagnosis results. The patients underwent the pre-operative MRI, MRS, and the CT examination with a complete data. Exclusion criteria receive a conservative treatment. MRI image quality was poor and can't be studied and analyzed. Complicated with other neurological diseases such as cerebral infraction, cerebral hemorrhage. We have the two group. One is the test group. Second is the violation group. Test group was conducted in my hospital. Images characteristics of the patients, large tumor diameters, primary brain lobe involved, whether it's cross midline, presence of perimetric edema, and clarity of borders, and the presence of enhancement region. We use the T2 flare mismatch sign or hyperflare rim. The MRS indicators we use the following index. Evaluation group was conducted in another hospital in my province, first affiliated hospital of Xinxiang Medical University. Evaluation of the AUC, accuracy, sensitivity, and the specialty of the mentioned model. Result from here we use the grade 2 and or 3. From here we can see most patient age is for IDH mutant is young, 20, 24, 23, 26. But IDH wild type most is more than 70%, 70 age. Oh, no, 50 years. And the grade 2 most is very young. Grade 2 most is a young patient. Grade 3 is also IDH mutant is young patients. For tumor locations, most IDH mutation is on the frontal. Frontal is most is IDH mutation. For non-frontal, there's some nearly 30% is non-frontal is IDH wild type. But for the frontal, we can see most of the frontal low-grade glioma is IDH mutant. Largest tumor diameter we can see for IDH mutant IDH mutant patients mostly have a larger tumor size because this is low grade, so the tumor diameter is larger. So we can see mostly the diameter is more than 5 cm, but for the IDH wild type is 3 cm. For the adenoma, we can see most IDH mutation have the adenoma. Tumor boundary, we can see both have most have a clear idea border, no matter IDH mutant or wild type. For RIM enhancement, we can see IDH mutation have the RIM enhancement. The p-value is very significant. For classification, we can see the IDH mutation have the communication some. For T2 flag mismatch sign, we can see the IDH mutation have the T2 flag mismatch sign, and some hyperflaring also 23 patients have the hyperflaring. T2 mismatch is 80%. So we can from here we can see the hyperflaring is better than T2 mismatch sign. And this one is the MRS data. We can see here is CTO2AA. Most of the IDH wild type have the maybe the low ratio. And CTO2CR, this is similar the result. This is the result of diagnostic efficiency. We can see the cutoff CTO2AA value, cutoff value is 3.2. AUC is 0.8. Sensitivity is 0.6. Specificity is 0.9. CTO2CR ratio cutoff value is 1.8. AUC is 0.7. Sensitivity is 0.6. The larger tumor diameter, we can see a cutoff value is 4.1. AUC is 0.8. Sensitivity is 0.8. Result. So we make this model. If we found this patient is IDH, I think this is even though you have a large tumor more than 1 cm, or even any condition CTO2AA ratio is more than 3.2. CTO2CR ratio is more than 0.8. This is the ideal. If not, this is the wild type. So we use this for the test. We test in the test group. We found that the sensitivity is 0.8. Specialty is 0.9. For violation group, we use this model. We can see the sensitivity is 0.9. Specialty is also 0.9. So discussion, which one is better to diagnose the IDH mutation, T2 flag mismatch sign or versus hyperflaring? From the former data, we can T2 in our panel. We can see there's 18 patients IDH mutant. We can, if we have the T2 flag mismatch sign, we say that this is the IDH. 18 patients have a good result. For hyperflaring sign 23, we can diagnose. Compare with the T2 mismatch sign, hyperflaring have a higher sensitivity in diagnosis in defining IDH mutant non-coded estroma, while specificity did not increase. So we think hyperfluorescence is better than T2 flat mismatch sign. So discussion CGO2A ratio and CG2CR ratio can serve as a reliable quantitative information provided for the clinical prediction of IDH mutant gliomas. So there's some typical cases. From here, we can see this is the T2 hair. We can see the hair T2 flare, uniform T2 flare, and the low flare signal. So this is a T2 mismatch sign, and this is the T2 mismatch, and the CGO2 ratio is 18 is 10.4. And the CGO2 CR is 7.7. So this is we think this is the IDH mutant. This is also T2 is a typical T2 flare mismatch sign. This is a high T2 signal, low flare signal. This is also the T2 mismatch sign. This is the IDH mutant. This one is also this one is have the high hyperflare rim for the in the middle. In this picture, second picture, we can see this is a hyperflare rim. We can see this is also the IDH mutant. This one is use our model. You have the configuration. So this is for this for you use our model. This is have the classification. This is the IDH mutation. So hyperfluorescence is specifically and the more sensitive marker for diagnosis IDH mutation astroma. MRS data can predict the IDH mutant glioma in low-grade gliomas. The predictive model for IDH mutant constructed by combined with hyperfluorescence classification, large tumor diameters, and the MRS data can accurately predict the IDH status of glioma pre-operative. So it's helpful for our diagnosis and treatment plan. Thanks. This is my team, and team is closely working with some other team in the world. Right now there's nine master students and a PG student in my team. So thank you.
Thank you very much for your comprehensive presentation. Oops, I think I'm missing. Okay, I'm not quite sure why my camera is not working now. Well, yeah, okay. So, is there any questions from the audience? Yes, go ahead.
Hi, Dr. Meng. It was a really interesting lecture. I have the doubt regarding the reliability on MRS. Now, over the past few years, there has been a lot of discussion like, is MRS really reliable or not? Because you have used this as one of the major factors in predicting. When we attend any radiologist meeting, especially in the oncosurgical circles, this is where the discussion comes. What is your take on that, since you have done research on this topic?
Okay. Actually, if your hospital have the 2Hg MRS, I think it's okay. I do not know the situation in Japan or in India, but in China, most hospitals don't have a 2Hg spectrum. If you have the 2Hg spectrum, okay, you can just use the 2Hg. It's okay. As in my opinion, I know most Germany, even Germany, don't have the 2Hg spectrum. This model for the patients just to bring the regular MRI, just bring the maybe MRI, no enhancement, just a regular MRI, we can guess, oh, this is IDH mutation. That's the main purpose. Actually, we are developing some other methods, basic research for this phenomena. So this is this model for most of the hospital in the world, because even in China, we only one hospital have a 𝒂𝒔 spectrum. I don't know the situation in India or Japan.
So basically, you're saying that the results with 20G spectrum are much better, so probably they're more reliable than the regular MRs.
No, this is just for the diagnosis. Yeah, before the operation, we can tell patients, oh, this is IDH mutant. If you just have the regular MRI, we can tell them that. This is a very easy way for some hospital, especially also Asian hospital. I don't know. So we try to use the simple way to do this. Use this one.
Okay. I think I can follow up on that MRS question a little bit because my research is on MRI. So he was talking about the 2Hg signal spectroscopy, right? And it is known that 2Hg, the spectrum of the 2Hg is really similar to glutamate and glutamine. So if you take a usual MR spectroscopy, even if you have a 2Hg analyzing software, the signal will be overridden sometimes by a glutamine and glutamate. So you have a hard time separating and detecting only the 2Hg. That is the main problem that people are having with the 2Hg spectrum for IDH mutant gliomas. Okay. Any other questions?
This is just another way, a simple way for the clinical people. Yeah.
Yes. So Dr. Lee was presenting just using calling an NAA to stratify IDH mutant gliomas. That's what I understood. That's right, Dr. Lee?
Yes.
Thank you.
Any other questions? It was a very interesting presentation. None? Yeah, I was curious about the consistency of the spectrums. Where did you target the ROIs? So it might fluctuate according to the location of your target. Dr. Lee, how was it?
Sorry, can you speak a little again?
Yeah, how did you determine your region of interest when you perform your MRS? Because the signal will fluctuate according to your target.
Also, we focus on the center of the tumor.
Okay, I see.
So I think in some other big hospital, if the patients have if the frontal tumor, the patient is less than 45 or 40, if they don't have the 2Hg spectrum, they say this is IDH mutation. In my center, if the patient have the young is less than 45 on frontal, nearly 90% is IDH mutation.
And do you have
my experience?
Yeah. And do you have any mechanistic explanation that you can provide to us of why your conventional MRS can be applicable for detecting IDH mutation?
Right now, we ask two master students to do that project. But I think if you meet one patient less than 45, you can tell it's low-grade GBM. You can tell this is IDH mutant. 90% this is right. 90%.
Yeah, interesting. Any other questions or comments that you want to make from the audience? No.
Yes,
Yeah.
we can, Sensei, we can ask maybe Alexander.
To whom?
Alexander, please.
Alexander?
Alexander.
Thank you.
From Ukraine.
Thank you very much. Dr. Lee, my congratulations. Very good investigation. You extended the abilities of regular MRI for diagnosis and for building of predictions and maybe for management of gliomas in this patient. Actually, everything was done absolutely clearly and methodologically very, very nice and elegant. I can say so. My congratulations and thank you for this, for your work, for the presentation. I hope that in the future this investigation will find their place in complex management of cerebral gliomas. So thank you.
Thank you very much.
What's the question? Sorry.
It's not question, it's just comment. It's just comment. Thank you.
Okay.
Just comment.
Thank you. Comment. Thank you.
Thank you.
Okay, so is there any other thing that somebody wants to make a comment, like Dr. Karaginov? Do you want to comment on something?
Well, no, thank you very not too much to say, but really this probably will give us in future a chance to start pre-operative chemotherapy, targeted chemotherapy. That has a future. Also, I would like maybe to reiterate your question, Professor Kinoshita, because we have a metabolite from the IRH, which is somewhere in the Krebs cycle and which is accumulating three carbonic acids and like this. Is that probably the reason for the change in the signal in the spectroscopy? We have to really know about that. And finally, the region of interest, is that in the center of the tumor or it is close to the this rim of hyperintensity? Because that is also of some interest. These are my 3 points to comment. Thank you very much for that.
Okay, Dr. Sukirti would like to close the session. And we are very thankful to Professor Casper, who gave us a lot of insight on Chiari malformations, a revision for a lot of us. Then Dr. Ming, who actually gave a lot of information on molecular, because right now the latest classification is all based on molecular diagnostics. And the youngster, Dr. Dean Huai, for giving her experience on difficult and different tumors. Any last comments by Dr. Yoko Kato, please? Sensei.
Okay, thank you so much. Kinoshita Sensei, ありがとうございました. It was wonderful, the chair of today's session. I think the 3 topics is a very variety in neurosurgery. I think we learned a lot from all of them, I think, especially the China. Dr. Min Ding, maybe we'll visit here again. So then maybe we want to ask the next report. Really, thank you very much for your great talk. Thanks so much. Okay.
Thank you. Wish you all a good day. I have to sign off.
Okay. See you next time, please.
All the best.
Okay.
Thank you.
Thank you.
Thank you very much.
Thank you so much. ありがとうございました。
元気で。
ありがとうございます。
ありがとうございます。